Okay, well, I think we'll make a start, and obviously people can join in the background as we go along. So good afternoon, welcome. This is, I think, the 5th of the Well-Led seminars that we've arranged just to help do a bit of preparation for the Well-Led inspection that's currently underway for our organisation. So just a reminder that well-led inspections are completed by the Care Quality Commission, so they're our regulator, and it sits underneath the Health and Social Care Act, and they're really testing to make sure that we as an organisation meet our regulatory requirements. From a well-led perspective, they're particularly interested in leadership across the organisation. And as I think we've said in almost all of these sessions, there's a lot of overlap across the different well-led quality statements that the CQC are looking for. So apologies for any further overlap in my session today. My plan is to run through a relatively quick presentation with you, taking you through what the CQC look for under governance and what they mean by well-led from a governance perspective, and what the CQC would see good as looking like. I'll also give some examples of how we meet the CQC's requirements and just a little bit of additional information on governance and some of our governance structures at the front end of the presentation. A lot about governance, as with all of these, is actually about us as leaders and what we are doing in our spaces with our teams. And obviously you're going to know that far better than I am, but hopefully today I can just help you to connect those dots between what it is that happens in your areas and how that meets the different requirements of the CQC, and how we feed all that information up and down our organisation. So if I can ask for main questions to be at the end, but if you do have any point of clarity or something particular to a slide I'm on, do please put your hand up. I'm going to be sharing my screen, so if I don't see your hand, please do shout or someone give me a nudge in case I miss. Okay, so hopefully you can see the presentation. So, Well-Led 5, Governance, Management and Sustainability. So what the CQC are looking for is that we as an organisation have clear responsibilities, roles, systems of accountability and good governance. That we use these to manage and deliver good quality, sustainable care, treatment and support. And that we act on the best information about risk, performance and outcomes, and we share this securely with others when appropriate. So there's a lot that gets sort of packed into governance. So it does look across roles, responsibilities and accountability. It also looks across quality assurance and management, and it brings in aspects of information governance and financial governance. So just for a little bit of context and to remind ourselves that for us, for the NHS, governance is all about our systems, processes and structures, and that we have those in place to ensure that healthcare services are delivered safely and effectively, and that what we're delivering is in line with our legal, ethical and financial standards. So governance really is concerned with accountability and decision making, and it's about every level of the organisation. And the CQC have that real interest in what we used to call ward to board, but from service team to board. How do we make sure that flow of information, that understanding of risk, of outcomes, of performance is happening up and down our structure? So to test us on this, the main thing the CQC will do is they will talk to us. They'll talk to our staff, they'll talk to our leaders, and they will have spoken to our partners. They'll also talk to our patients, our service users, carers, and a lot of that conversation will have already happened through inspections they've done recently, and they'll test and review some of our processes. So they've already put in their evidence request asking for quite a lot of data and information. So they'll already have had that, and they'll already have started to analyse that, and they'll be looking to triangulate what they've read, what they've seen when they're out in our services, with what we then say when we talk to them under the Well-Led review. So governance. Broadly, governance sits under 4 key sort of areas. We have clinical governance, so that's all about the continuous improvement in the quality of patient care. We have our corporate governance, which is focusing on the NHS organisation and how we're being directed, how we're controlled through our governance structures. Information governance, so how we're handling our patient data, and accountability. And that sits both within the organisation, but actually the accountability the organisation has to other people, so other NHS bodies, to our ICBs, so our integrated care boards, and of course the accountability we have to NHS England, CQC, NHS Improvement, and ultimately to the government and to the public that we serve. Quick reminder of the EPUT governance. So I always think about EPUT governance kind of set out in 5 areas. So what we're trying to do is make sure our board of directors have that broad knowledge and understanding of risks and performance in our organisation, to ensure that the decision making is made based on really good risk management and understanding. So they receive a lot of strategic assurance, which comes up through our standing committees. So we have our quality committee, our audit committee, our people, it's now called the people committee, our finance and performance committee. They're our kind of core standing committees. We do also have, I think, charitable funds, and we still have, as all organisations do, nominations and remuneration committee. So they're kind of our standing committees that report directly into board. For them to function, what they need is sort of tactical operational information, and that comes through our executive level groups. And feeding up to them is our delivery oversight groups. And ultimately, the place where it's all happening is our service, so our service operational groups. And it's about how do we make that information flow through those different layers. So just for your information, there's a quick graph that shows you for the standing committees who the committee is, who their tactical group is. So I'll take quality. Quality has a quality of care group, was previously the safety of care group. And safety of care, experience of care, and I think it was effectiveness of care were the 3 groups originally, but we now have a quality of care group. And sitting under them, we have a whole range of what I would call almost expert clinical committees, expert groups that really focus on specific areas in the organisation. So that would include things like our Mental Health Act groups, our learning groups, end of life. So real expert areas. And then feeding up, we have our local. So our operational groups feeding up into that structure. Our other standing committees have the same, very similar structures. Most go through some form of executive operational group, but we have a lot of really interesting groups that work on sort of transformation. The EPUT Lab looks at innovation, and of course our capital group, which helps us with taking forward capital projects in the organisation. And again, that's all fed by the service management team. So service management team and accountability. And it's really from there that we are being influenced as to what those committees should be focusing on. Okay, so what does good look like? So I'm going to start with 3 areas. So as an organisation, we should be able to evidence how governance and management systems enable delivery and monitoring of high, safe care. I think that should be a high standard of safe care. Governance processes enable routine submission and notifications to the CQC and other regulatory bodies, and that management, workforce and other systems are used to maintain financial sustainability and staff are proficient in their use. Okay, so we have lots of examples of how we do this as an organisation. This is our committee structure. This is our accountability framework. This all comes through our risk management assurance framework, so how we manage and escalate risks. We have really clear documents around development and review of policies and SOPs that absolutely ensure that as an organisation we're following best clinical practice, and that we're following legislation. We have our quality of care strategy that absolutely underpins all of the different work that we're doing across the organisation. We have a very practical governance manual, which gives all sorts of things, including things like our scheme of delegation. We have lots of information around CQC. So as an organisation, it's really important we understand if we're complying with our regulatory requirements. So we have an assurance framework that goes up through our quality committee, and we do a whole framework of visits. And I'm sure most of your services will have had a visit from the compliance team at some point, or a quality visit with our partners. We actually report to the CQC and most regulatory bodies through our DATEX system. So actually, when you fill in your incidents, if it meets a certain criteria, it will automatically be notified to the CQC. That was a national initiative to really avoid duplication, but there is some specialist reporting, particularly around the Mental Health Act, where we have very specific bits we would report. We have a whole range of enabling strategies, which I won't go into in detail, as we covered that in the Well-Led 1 presentation, which are all around enabling us to meet the Trust strategic plan and objectives. As an organisation, we really understand where we are with our different work streams, and a lot of that is through the reporting. So we do a lot of annual reporting and often more frequent reporting. And actually in those, if you look at our annual reports, there is a really good focus on both the activity that we're doing, but also looking at what are the risks, what are the challenges, what are the work plans for the next year. We have robust financial reporting that all goes through our Finance and Performance Committee, really clear reporting on where we are. And one of the things I want to highlight, and I know it's a bit of a peculiar thing to highlight, but actually when the CQC came to visit us last time, they commented that, you know, we had all these amazing things and we were moving forward, but we didn't have EPMA yet. So one of the really exciting things we can talk about this time is we have now launched that. So governance is always growing and evolving. Things are always changing. And last time the CQC came, I think from a governance perspective, we were still embedding a lot of these things. The accountability framework was new. We just refreshed the risk management framework. We had a safety first, safety always strategy, so we didn't have quality of care at that point. So I think the difference this time is we're at a place where we should be talking about how these things have been embedded for us as an organisation and how they've become business as usual. And this is really important because it makes sure that we do have the structures to support the delivery of our strategy. It means that our risks and service challenges can be escalated at all levels of the organisation. It means that local risk should inform what risks are included on our risk register and what goes up into our board assurance framework. So what are the risks the board are seeing and the board are managing? As I said, we make sure we have clear policy and guidance that reflects national best practice. That we as leaders and that services understand our requirements under the Health and Social Care Act, which is ultimately making sure that services are safe, effective, caring, responsive and well led. We often call it CQC, the CQC standards, but actually this is about meeting the Health and Social Care Act. It's not about the CQC as an entity. Our accountability approach, which devolves leadership and brings empowerment to leaders to drive improvements in their care units. And of course, we discharge our powers under the Mental Health Act and the Mental Capacity Act. So important to be safeguarding our patients under those powers. Okay, so alongside this, we also need to have clear management structures. Leaders need to clearly understand the CQC regulations, any legal requirements and other requirements and implications. We need to ensure that we have robust personal development and appraisal for staff, that we have one-to-one supervision time for staff, and that we are aiding staff's personal development, and that we have clear processes in place for performance management. And one of the things that I think we all know with the CQC, all conversations must be recorded. If you didn't write it down, it's a bit like inquest. If you didn't write it down, it didn't happen. So again, for us, what's really important is that we have those directorate and care unit structures. So you know where you as leaders sit in that structure and your staff know where they sit. We all have job descriptions that are clearly matched, have very clear roles and responsibilities. We have processes to make sure that our policies and clinical guidelines really do outline each person's role and responsibility. Obviously, we have supervision and appraisal policies and documentation to make sure we can support staff in completing those. We do have a disciplinary policy. Sometimes people don't behave in a way that is appropriate. And as an organisation, we need to be comfortable having those difficult conversations, supporting the person in every way possible. But ultimately, there's times we do have to move to disciplinary. We have our maintaining high professional standards policy. very similar for our medics. We have our code of conduct for our directors. So it doesn't matter where we sit in the organisation, it is the same. We all have a code of conduct that we have to abide by. And for EPUT, that's wrapped up in our behavioural framework and our vision and values. And again, why it's so important, it's important that you as leaders and that your staff know where you sit in the organisation, you know your roles and responsibilities, that the governance leads in our organisation are really clear on their portfolios and priorities. So, you know, our infection control team, they know exactly what the infection control standards are. They know what we need to meet as an organisation. They are our experts and they are there to guide. Staff need to feel supported and listened to. We've picked on that through other sessions earlier in the week. But again, it's a key part of governance. That is part of how we learn, how we grow. And that we take action to address behaviours not in line with our vision and values. Okay, so within governance, management and sustainability comes performance and data protection. So as an organisation, performance is continually monitored at a senior level and actions are taken to respond to emerging risks. This is what the CQC is looking for. This is what they're saying good looks like. We should have a director level called a COT guardian. We must have robust records management policies and retention policies in place. We must ensure we're complying with the general data protection requirements and that we're submitting what's called the Data Security Protection Toolkit each year, which is us giving assurance that we meet that, and that we have policies in place to protect against breaches and cyber attacks. So there's some really interesting live examples now. Again, moved on since last time CQC were here. When they were here, we'd only just started live dashboards. So they just had the first couple of indicators. So hopefully that's a really exciting development we can talk to the CQC about, and that leaders can talk to the CQC about how they use those dashboards, how they're helpful to them. We've continued to have our quality and performance indicator reporting, so that will come through your accountability meetings. It goes into standing committees and our board to see a set of quality and performance indicators. And we have our patient safety dashboard. So our performance monitoring has gone up a whole level really since the CQC were last here. Our medical director is our COT guardian, and we have very robust records management and storage and information governance policies and training in place across the organisation. And this is important because it means that we as an organisation are using our data and we understand how our services are performing over time. It's not about so much the individual dips, it's about sustained concern or sustained improvement, because obviously that's really what we're looking for, is that service is sustaining a good level of care. It means that we as an organisation are using a quality assurance and quality control IT system. And again, that brings us back to that aim of having the right information that we can then share from board or from team to board. That we as leaders can be aware of areas where we need to make improvement. And as I said, I think it's really important we also know where our good performance is. Yes, we definitely need to be able to say to the CQC, these are our challenges and this is what we're doing about them. But it's also our opportunity to tell them, but this is the stuff that's going really well. These are the things that are working really well. And of course, sharing that with each other. And of course, information governance is all about making sure ultimately that as a trust, we're safeguarding the privacy of our patients. We need to make sure that our records are clear, they're in place and enable communication across clinicians so that clinicians know the different needs and risks of the person in front of them. And ultimately that we're keeping our records and our cyber security in line with national guidance and national requirements. Okay, so good also means that we have business continuity plans and contingency plans in place that we regularly review. That we have directors that are proactively supporting service delivery, and that we are seeking the views of staff, service users and other stakeholders to improve our services. So BCPs, business continuity plans, we all have them. So every service and team has a BCP. Most are reviewed every 2 years. There are a few that are reviewed annually, certain corporate ones. And we do report BCP compliance through accountability. We do staffing reviews. We continually review staffing. We encourage staff to be reporting if there are low staffing numbers on shifts, and all of that information then flows up through that governance structure so that we can understand where we need to create capacity in the organisation. We have a huge array of workforce KPIs, of service KPIs, so a lot of information that's available to us. It's all about how we use that. We actually use people with lived experience a lot in the organisation. I think it was really quite exciting listening to Matt Cisco, in one of the previous sessions around all the different ways that we engage with people. But actually, that's a core part of governance, because our governance should be around making sure we have an organisation that works for the people that we're providing services to. Our governors are an important part of that. They are the public. They represent the public that we serve. Active feedback, again, really important through the governance process, and making sure that we engage with our commissioners and that our commissioners engage with us. And we do this so that all services know what to do in the event of a business continuity incident. BCPs are one of those awful things that sits on your shelf that gathers dust and everybody hates updating. But the minute all the water goes off, or we have a flood, or we have a fire, they suddenly become really important, because they're the document that just helps you guide you through that situation and guide you through that process. Staffing reviews, incident reporting. This is all about making sure we have safer staffing levels, the right staffing levels and right skill mix on our wards and in our teams. Having the range of information, again, is about making sure we as leaders understand where there's risks in our workforce and we can react to these, and where there's risks in our service delivery, and again, so that we can react to these. And ultimately, we're seeking and continually using feedback from multiple sources to improve services. I just wanted to highlight that last time the CQC came, it was back in 2022. They actually issued what they call must-do actions. So they were regulatory breaches relating to governance. So there were 4 areas we were asked to improve in. So the first area that they were concerned about is around our process for implementing and monitoring improvement. So what they meant by that is they'd visited us previously. They'd found concerns, particularly around observation and engagement and around medication. And when they came back, we hadn't made a difference. We hadn't made a change. So that meant, as an organisation, we had to sit back and think about, okay, so how do we make change following things like a CQC inspection? So we did a full review of our internal process for responding to CQC inspections. We worked to really look at how do we ensure we're setting smart actions, so that we're not doing a sort of knee-jerk reaction. We were stopping, thinking, and trying to understand what would actually make a difference. We used the SEEPS process to really think about why the CQC were finding some of the concerns they were, and setting actions that would help address that. And we implemented and embedded a whole new system around seeking evidence assurance. And I'm sure there were a few of you on the call that were probably a bit fed up with me nagging last year. But what I found really exciting about the new process is, before we close an action plan now, we ask for an evidence assurance presentation. And that goes now to our learning committee, so to the LOSC. And the idea is to talk through what the issue was and what the changes that's been made, and how that actually feels for staff in the service. What difference did we make? And I think they're fantastic presentations, because they talk about such positive change in the organisation. The CQC also felt that we needed to further embed our governance systems, and actually make sure that we can review and enable the identification of issues affecting the quality of care being delivered. So this really was one of the things that influenced our new quality of care strategy, which is very clear on the EPUT quality priorities. We implemented a new quality assurance framework, which a lot of people call the QOF. And we brought in new risk and compliance reports for accountability meetings alongside the live dashboards, to try and really highlight those issues affecting the quality of care. As a trust, we were asked to improve the quality of our data. They felt the effectiveness of some of our systems and the accuracy of assurance received about the quality of care wasn't quite where it needed to be. And that was a couple of things that came out where people, I think, struggled a little bit to look at the data that was provided by our performance teams and in some of our systems, and kind of square that off with where you felt you were from a performance perspective. So a lot of work was done in that area. We've started a program of development of ESOPs, which is all about trying to help the correct data entry, because actually it's all about having the right information on the right system. There was a lot of campaign and training that was undertaken about the importance of data quality, and there was a review of the data quality committee and its assurance reporting pathways. And the team were accredited to BSI 10008. But ultimately, the change is about using the same data in the organisation. So we now ask that everybody uses the data that comes through your accountability meeting. Data always looks different when it's taken at different points in time. And for consistency, what it is, it's about looking at the same data. And finally, they asked that the Trust ensured we have a robust and timely plan for the implementation of a consistent patient record. So ultimately, this was all about our new digital strategy and the fact that we're moving forward with Nova, which was in absolute infancy when they came to meet us before. Now, obviously, you can't land a whole new patient record in a couple of, well, you can't even do it in a couple of years, never mind in a couple of months. And that is a huge digital strategy that's being taken forward. And again, I'm sure the CQC would be really interested to hear how that's progressing and how the leadership team and clinicians are involved in that. But in the meantime, there was some upgrade work done to HIE, which has now changed name, and we enhanced the shared care record. Okay, so aware governance probably isn't the most interesting topic to have taken you through, but ultimately where we want to get to is that as an organisation and as a leadership team, we can clearly articulate that we have an effective governance, management and accountability system, that we can articulate how our staff understand their roles and responsibilities, and that we as a leadership team account for the actions, behaviours and performance of our staff. That we as leaders implement the relevant mandatory quality frameworks, recognise standards and best practice to make sure we're improving equity and experience and outcomes for people using services, and that we tackle known inequalities. That our systems to manage current and future performance and risks to quality of services, we use that to take a proportionate approach to managing risk that allows new innovative ideas to be tested within the service. So again, that's all about understanding your risks and understanding how to make risk-based decisions. We need to be able to articulate those robust arrangements in place for the availability, integrity and confidentiality of data, records and data management systems. And that we're able to articulate how we use information to effectively monitor and improve the quality of care for our patients. And ultimately, we need to be able to give assurance that any kind of data or notifications that are required are submitted to external organisations as required. I say predominantly that's CQC, but there are a few others. So we do report to people like the HSE, so the Health and Safety Executive. We would do that through what we would call RIDDOR reporting. But again, that all comes through DATEX to try and make sure we avoid that duplication. Okay, I feel like that was a lot of information, so I'm going to stop there. And hopefully I haven't overloaded you too much. Do you have any questions or observations or any good practice you'd like to share? Claire?
Sorry, come off mute, shall I? Yeah, thank you. That was really helpful. Thank you very much. I just want to ask the bit where you were talking about the last well-led inspection, which I remember it because I was here then and I was talking about complaints. But can you is there somewhere we can access that report? Because I was just thinking I want to go back and see what the recommendations were for complaints so I can make sure that I'm on top of that. Is it saved somewhere, or should I mean I could probably find it online anyway, could I?
No, you can, but we'll find it and send it over because the report's huge, but probably the bit you're interested in is the top part. So right. I don't know if I can ask Lara or someone from the team if we can just extract the top part of the report. I don't think there was a lot from a complaints perspective. It was mainly around, I think there was a recognition that we were moving from an old way of working to a new way of working. So again, they're looking for that embedding. So this time around, it's going to be about talking through how that change worked, and hopefully that we're in a much better place now with responding to complaints and using that information.
Okay, all right, thank you.
But yes, we can share that, of course. We'll share it for everybody.
Lovely.
Okay. Well, thank you very much. Thank you for listening. Hopefully there's something that will help a little bit when you go forward for Well Led. We will be making all of the presentations available, and we'll be setting up a Microsoft Teams page where we'll be putting a set of information that people can access just as part of preparation and for your own sort of development and reading. So that will be going live next week. In the meantime, comms are putting the different videos of these, the recordings of these sessions up and available on the intranet for us. If you do think of any questions or anything you'd like to ask after the session, please do feel free to contact either myself or someone from the compliance team. I'm happy to have a chat through. And if you are one of the people that's been approached for interview, again, if there's any questions you've got, more than happy for you to approach me or the team just to have a chat through what that's likely to be. Lovely. Well, thank you all very much. Have a nice rest of your afternoon.
Thanks, Nicola. Bye.
Bye.
Thanks, bye.